Okay. Hi, and good morning. So, for those of you just tuning in, I'm Meryl Friedman, the Senior Director of Disability Policy Engagement at Anthem, and welcome to the third session of the 2020 Fall Award Campaign for Social Insurance Kickoff. Our session is Medicare and Medicaid at 55. Where are we now? So we're super excited, but a couple of housekeeping items. A quick reminder that at 5 o'clock this afternoon Eastern Time, we'll have a social insurance appreciation. So if you've already purchased a ticket or sponsorship for the Full Ball Award campaign, you've already received the link for the social hour, but it's not too late to make a donation, get the special Zoom link for this. I know you guys probably already know this, but every dollar helps. So we hope that you can join us. If you're unable to purchase a ticket or sponsorship today, a contribution of any amount is welcome when you can, and we truly appreciate that. After you make a donation, you'll receive an email with the Zoom link for 5 o'clock today if you get it done today, and we'd love to see you there. So a little bit about Medicare and Medicaid at 55, where are we now? In July 2015, the Academy hosted a series of events for the 50th anniversary of Medicare and Medicaid, including an event in conjunction with the release of Medicare and Medicaid at 50, America's Entitlement Programs in the Age of the Affordable Care Act. Just 5 years ago, let alone 55 years ago, nobody would have imagined that we'd be here in the middle of a global pandemic with the highest unemployment rate since the Great Depression and healthcare disparities as a priority for us to address as a nation. The COVID-19 pandemic has and will continue to dramatically alter the delivery of healthcare services and the role of Medicare and Medicaid in our current healthcare system and our society as a whole. As I always say to people, we have a great obligation here, a great obligation. So, fortunately, you will not be listening to me the entire time. We have a fantastic panel. I'm so excited to hear what they're going to talk about and be part of this. So I'm just going to go through one by one, give you a little bit of background, then we're going to jump right in. But John Oberlander is the professor and chair of social medicine and the professor of health policy and management at the University of North Carolina, Chapel Hill. He also holds an adjunct appointment at the Department of Political Science. His research and teaching interests include healthcare politics and policy, healthcare reform, Medicare, and American politics and public policy. His recent work explored ongoing political fights over an implementation of the Affordable Care Act, healthcare cost control, Medicare reform, and the fate of the Children's Health Insurance Program and Independent Payment Advisory Board. Speaks regularly to community groups and medical professionals, and you all today on healthcare reform, the Affordable Care Act, and Medicare. So trying to translate the complexity and technical detail of health policy into something more understandable and accessible. Thank goodness, right? John Rother is the president of the National Coalition on Healthcare, America's oldest and most diverse group working to achieve comprehensive health system change. The coalition's membership of more than 80 participating organizations includes medical societies, businesses, unions, healthcare providers, faith-based associations, pension and health funds, insurers, and groups representing consumers, patients, women, minorities, and persons with disabilities. Prior to joining the coalition in 2011, it's just really important for me to note that he served as the longtime executive vice president for policy strategy and international affairs at AARP, where he led the development of their policy positions and advocacy strategies. Ann Schwartz is the director of Medicaid and Chip Payment and Access Commission, also known as MACPAC in our world of acronyms, a nonpartisan legislative branch agency that provides policy and data analysis and makes recommendations to Congress, the Secretary of the U.S. Department of Health and Human Services, and the states on a wide array of issues affecting Medicaid and state children's health insurance program, also known as CHIP. Dr. Schwartz previously served as a deputy editor of the journal Health Affairs, vice president at Grantmakers in Health, which is a national organization providing strategic advice and educational programs for foundations and corporate giving programs that are working on health issues. And last but certainly not least, Paul Ginsberg calls the Leonard D. Schaefer Chair in Health Policy Studies at Brookings Institution. He's also professor of health policy at the Salt Price School of Public Policy, University of Southern California, and also serves as the director of public policy at the USC Schaefer Center for Health Policy and Economics. He is leading the Schaefer Initiative on Innovation in Health Policy, which is a joint program between USC and Brookings. Also a noted speaker and consultant on the changes in the finance. Last but certainly not least, Paul Ginsberg particularly on the evolution of healthcare markets. In addition to presentations on the overall direction of change, recent topics have included cost trends and drivers, consumer-driven healthcare, provider payment reform, price transparency, the future of employer-based health insurance, addressing growing provider leverage and competition in healthcare. So now you know why we're gathered here with this incredible panel, why I'm not going to talk too much. So I'm just going to kick it off right here, and I think we have a couple of questions. We're certainly going to open it up to Q&A with the audience as well that have joined us today. So John, as we start to talk about how have Medicare and Medicaid evolved over the last few years prior to the pandemic, I'm going to toss it over to John Rother to kick us off and open up the conversation.
I'm honored to be part of this panel. Can you hear it all right?
Yes, we can. Thank you.
Okay. Well, there's a lot to say, and I'm not going to try to say it all. I'm going to focus just on Medicare and also the developments that I think are most significant for its future. So there are six, and I'll run through them fairly quickly. The first is there are ongoing changes in the healthcare delivery system that Medicare has supported, most notably the move to payment reform, shifting from volume to value, and an increased role for capitation. So Medicare is a very important leader in that, and that has continued in these last few years and accelerated. With that, we see an amazing growth. The second development is the growth in Medicare Advantage plans, and in particular, the ability now for those plans to address the social determinants of health, which really moves healthcare in a much broader direction to encompass housing, nutrition, and even isolation, things that are important for health, but have not been part of health care until recently. The third trend that's not so positive is growing consolidation. We've seen hospital mergers, we've seen hospitals purchase the many physician practices. We've got in most places now really a monopoly type situation where competition is just not possible. So that's a big change from how Medicare has structured delivery system in the past. Now we're dealing with very, very large institutions that can control much of healthcare delivery. The fourth change is we have, of course, now the ability to pay directly through Medicare and other sources for testing for COVID. And I think we will have the ability to also pay for treatments for COVID separately from the way we pay for other services and other tests. And this is a move toward a much greater role for Medicare in public health. And I think it's a positive role, but I think it has implications beyond the pandemic. Fifth, and maybe the most promising, is the recent liberalization of payments for telehealth. And now we're seeing, I think, an explosion of finally seeing healthcare and Medicare catch up to the possibilities of electronic interaction between patients and physicians. And finally, I do think that last few years we've seen, especially last year, intensity around the idea of expanding Medicare, whether it's Medicare for all or, as the former Vice President Biden has proposed, expanding Medicare coverage to those 60 and above. So we're going to see, I think, a serious debate about how to build on Medicare for other people as well as those 65 and over. Now that's it.
Oh, John, no, thank you for your thoughts. And I think, you're speaking about Medicare leads into, the conversation with Paul. We're going to toss it over to you. That's your heads up, Paul. You're coming up next. But two really of the salient points that we're not going to dive into here quite as much, is really those drivers of health, like really looking at healthcare holistically and addressing social isolation and food insecurity, health, homelessness. And so I really appreciate you giving a shout out. Of course, the 5 years of changes we've made to telehealth in 3 weeks, is what we felt like for a while, and where we'll go with that, right? So Paul, we're going to follow up with you now to talk a little bit about Medicare Advantage enrollment.
Oh, thanks, Meryl. First, I want to mention that while I'm the vice chair of the Medicare Payment Advisory Commission, or MedPAC, I'm speaking on my own behalf today. What struck me in recent years is the rapid growth of Medicare Advantage. Those are the private plans that beneficiaries can opt to enroll in and get their care through the Medicare Advantage plan rather than through traditional Medicare. And from 2010 to 2019, enrollment roughly doubled. It's now 34% of Medicare beneficiaries. And if you look at those eligible to enroll, namely those who are enrolled in both Parts A and Part B, it's 37%. And in recent years, Medicare Advantage has been seen as a very attractive business for insurers. There's a lot of entry into it. Now, what's striking is that this is contrary to the predictions that the tightening of payment rates in the Affordable Care Act would lead to declines in the size of this program. And a likely explanation would include innovation in care management by the plans under the pressure to reduce costs, plans collecting more quality bonuses by raising their scores, and also some less desirable actions such as merging their low-scoring areas into their high-scoring ones, and more aggressive coding of enrollee risk to get higher risk adjustment payments. An irony for those who are advocating Medicare for all is that so many Medicare beneficiaries have made an active choice to enroll in the part of Medicare that is run by private insurers.
Mm-hmm.
Thank you, Paul. So John Oberlander, do you want to pick up from there and address Medicare for all of it?
Sure, and let me see if I can put John and Paul's comments together.
Wonderful.
You really have this extraordinary tension that Paul was just alluding to, where you have really the privatization of Medicare insurance. That's what's been going on in the program for quite a while, and it's accelerated rapidly, as Paul was just detailing. And so you have that ongoing privatization of Medicare insurance at the same time as you have the reemergence of Medicare as a model for national health insurance. And it's worth remembering that excuse me, the original Medicare vision was Medicare for all. And reformers, after Medicare was enacted, for a number of reasons I won't go into, that's a different panel. But for a number of reasons, reformers really got away from that in the 70s and 80s. And instead, the dominant models of health reform expansion in the United States were linked to building on private insurance and Medicaid, not Medicare. And what's happened the last couple of years from a historical perspective is extraordinary, which is Medicare for all reemerging as front page news, as a front page option. We saw an almost bidding war in the Democratic primary. And of course, Bernie Sanders had the opening bid 4 years ago, but Elizabeth Warren and Kamala Harris and others, and even those who did not have Medicare for all plans, wanted to borrow the rhetoric of Medicare, the appeal of Medicare. And so Joe Biden and Mayor Pete and others talked about a, quote, Medicare-like public option, in addition to talking about expanding Medicare eligibility, as John was talking about. So that is really a transformation of Medicare's place in the healthcare debate, and really, I think, a change that would have been hard to predict 5 years ago. And I think it reflects in part dissatisfaction with the Affordable Care Act. it reflects in part the near-death experience the Affordable Care Act had against Republican repeal and replace in 2017. And I think it reflects growing recognition that we have a problem in the United States, not just with the uninsured, but with the underinsured. And that that sense that there's pervasive health insecurity even a decade after the ACA was passed.
Mm-hmm.
Yeah, I couldn't agree more, John. Thank you. And I think, the evolution of Medicare, we take a little bit of a transition kind of quickly here to the evolution of Medicaid and some of the changes that have taken place. Again, now we're on the pre-pandemic part of the discussion. So, exciting to see when we transition the conversation further along for mid-pandemic. But Anne, we're going to turn it over to you to talk a little bit about what those Medicaid changes look like.
Sure. Thank you. When you work in the Medicaid space, you get used to going last. And I think that's sadly true for Medicaid providers and Medicaid beneficiaries, but I'll do my best to paint a picture. I mean, it's been a very dynamic and exciting, I would say 10 years in Medicaid policy. Obviously, the Medicaid expansion to non-disabled adults led to huge numbers, some 15 million people gaining health insurance coverage as a result of the Affordable Care Act, many more than have gained coverage under the exchanges. And now we have 36 states plus the District of Columbia that adopted the Medicaid expansion. So a very substantial change in the program. But while that has dominated, I think, sort of the popular imagination on changes in Medicaid policy, there are other substantial changes as well. In rebalancing in Medicaid's role as providing coverage for long-term services and supports. In 2011, it was the first time that states were spending more on home and community-based services than on institutional care, and that trend has continued. Something that I think the pandemic has shed some new light on, and we can talk a little bit more about that. Medicaid's also played a really key role in responding to the opioid epidemic. Commercial payers do not have as robust a role in covering those services as Medicaid and certainly than Medicare. Medicaid's paying about a quarter of substance use disorder treatment. The population obviously has a much more likely to report drug dependence, but also Medicaid beneficiaries are 3 times more likely than others to actually get treatment for their substance use disorder. And then the fourth item I really want to call attention to is I really think that Medicaid has shifted in the public's eye in its role as a coverage source for other people, for people who are sort of who are not front and center in the average American's lives. And I think in part this is because of the focus on Medicaid that came as a result of the 2017 debates on repeal and replace, that I think people are really understanding now how much Medicaid touches the average American's lives. It may be a child who's covered on Medicaid and CHIP when the parent doesn't have coverage. It may be someone's uncle who has developmental disabilities and Medicaid is their source of coverage. It may be your friend from college who has severe mental illness and is also covered by Medicaid. So Medicaid isn't just covering some other group of people, but Medicaid is really front and center in people's lives. And I think it has been a substantial change. That being said, I think the debate on Medicare for all has been interesting in the sense that there was sort of just an assumption in some of these proposals that Medicaid would somehow just be swept up into a Medicare coverage model. There are things that Medicaid does that Medicare doesn't, a lot of unanswered questions about the role of Medicaid under a situation when we would want to see, where we might be expecting more public coverage for acute care. I will leave it there. I would say on the issue of managed care and privatization that, Medicaid has long had much higher rates of managed care coverage than Medicare. The debate around, whether things should be in managed care or in fee-for-service has largely become a moot point in Medicaid, although there are still substantial parts of the program that are being paid under fee-for-service arrangements. It hasn't solved all our problems, many more to be addressed.
Many more to be addressed. Yes, thank you, Anne. And I'm going to transition a little bit. I will say, Anne, you're not going last on the next one. We're getting Medicaid out there much sooner on this next round of questions. I in solidarity with you on that. So, how has COVID-19 and the response legislation affected and exposed the current issues in the delivery of healthcare services? Because clearly, we've been talking about this for the last couple of months. We know there's plenty to discuss. And we're going to I'm going to toss over to you, John, as we talk about the erosion of ESI that's not designed for pandemics. I think we're finding with all of the warts exposed in the healthcare system at large that many things aren't designed for pandemics. But here
Yeah, so I think my role is to say a few brief comments so Anne can catch her breath before speaking again, which I'm happy to do.
Thank you.
So, I think it's worth thinking about historically. Medicare and Medicaid were designed to coexist with employer-sponsored insurance. They were designed to complement it. They were designed to extend government insurance to populations who did not have ready access to employer-sponsored private insurance. And so Medicare, Medicaid, and employer-sponsored insurance have been those three great bastions of American health insurance for the last 50 plus years. In that entire half century plus that they've existed, we've never had a period where there has been such a threat, such a destabilization of employer-sponsored insurance. And it raises major questions about the role of both programs, and Anne's going to talk about Medicaid in a second, which obviously is designed to be countercyclical, so has the most direct connection to the erosion of employer-sponsored insurance and COVID. But it also raises questions for Medicare as a platform, as a model. Right. Bernie Sanders and others have proposed plans where Medicare would cover folks who have become uninsured, and harkening back to what John said originally, right. Ideas about Medicare for all or Medicare for more or Medicare-like public options, I think are all seen in a different context in light of the erosion of employer-sponsored insurance. And I hope that was enough time to allow you to catch your breath.
And it was enough time for me to actually apologize for somebody who works very hard to make sure that everything is in plain language for all people to understand. I did use the acronym ESI for employer-sponsored insurance, so my apologies to the listeners. But Anne, a little bit, this time on Medicaid, right, and the immediate impacts and effects on, the acute care system and long-term services and supports. Clearly, there is no greater time to be talking about prioritizing the HCBS, the home and community-based services infrastructure, as a healthcare system, writ large. So love to hear your thoughts.
Sure. I mean, when I think about how the pandemic is affecting Medicaid and how Medicaid is responding, I think there's sort of short-term, middle-term, and long-term issues, and they're both health system and broader economic issues. I think in the short term, states have really scrambled to work with CMS, and CMS, while I think getting a sort of a slow start, has actually responded pretty vigorously to states' requests for flexibilities, whether that's under certain waivers or different types of state plan amendments. But I think the pandemic has, in the short term, it's really shed a light on weaknesses in long-term services and supports. Obviously, the high rates of deaths in nursing facilities and concerns about who is keeping watch over issues around infection control practices, the issues around the working conditions and the availability of PPE for those who work in nursing facilities. These are longstanding issues. They've just been sort of risen higher in the public attention. I think similarly, while I think there's a concern, well, we should be trying to do more to keep people at home or not just charging them from the hospital to institutions. We have similar problems on the home and community base side. Same issues around low pay, concerns about working conditions for home care workers, and the infrastructure being weak there as well. I mean, states are trying to shore up payment rates for LTSS providers and provide retainer payments. On the acute care side, I think the Medicaid providers have been sort of last in line to get relief payments, and are many still the Medicaid dependent or Medicaid only providers still waiting um, uh, to get relief funds. I think we don't really have a clear sense yet. We have a lot of anecdotal information about how, say, pediatric practices or behavioral health care providers are trying to navigate their way through having closed doors, but we don't really know yet where we'll be in the middle term in terms of what is actually left standing of the safety net, and then also what happens to this period in which people were not seeking acute care. What is that effect going to be on sort of long term on access and outcomes? For example, kids who miss their immunizations, are they going to get caught up on those? What is going to be the long term effect on people's health outcomes? I think the data that were released yesterday from CMS, which purportedly they're based on Medicare data, show a really troubling picture for dually eligible beneficiaries. And I hope they'll be digging more to sort of tease out the issues around what the issues are that are independently related to poverty versus institutional status. I think long-term Medicaid is really going to be we're expecting a huge influx of enrollment as people don't go back to work or lose their employer coverage. We're just getting a glimmer of that now. We expect that to be happening more over the next several months, and we expect that it will have a long tail as the economy takes a long time to recover. And also as states, we're already seeing states sort of planning as they enter their next fiscal years for declining state revenues and the effects that is going to have on Medicaid.
Right. So, Meryl, I'd like to jump in. I think there's three other things that we ought to recognize. One, in the last 5 years, we've had a series of public referendum in the non-expansion states, and I believe every single one has supported Medicaid expansion in that state. I think it's stunning the level of public support, even when the political leadership has been opposed. Secondly, I think private delivery of healthcare in the form of managed care is here to stay. There's no longer a serious debate. But so what is social insurance then? Social insurance is about how we finance that care, not how we deliver it. And so when we talk about Medicare, now it's becoming more focused on a financing structure rather than a delivery structure. And the last point is, of course, healthcare costs are going to be a challenge. They always have been, but even a more acute challenge now as the cost of the pandemic mount up. And we're going to be forced to get much more serious about changes in Medicare, more so than Medicaid, designed to lower the rate of growth and lower cost individuals.
So picking up on the healthcare delivery system and the provider side, Paul, do you want to weigh in for us, please? A few comments on telemedicine and alternative payments?
Oh, sure. There's just one thing that John said I'd like to disagree with.
Please do that.
My reading of the enthusiasm for Medicare for All is that a lot of it is a backlash against the role of private insurers. Now, I agree with you that on a practical basis, private insurers' role in the healthcare system is really more established and probably more earned than it has been in the past. But I don't think you should let people off the hook who were, who include in their Medicare for All proposals that there be no private insurance. But let me go on to some of the COVID-19 changes in Medicare. What's really striking has been removing restrictions on telemedicine and paying the same rates for video and telephone visits as in-person visits. Now, this has really accomplished a lot during the pandemic by maintaining access to care for patients and also reducing financial stress on physician practices, which have experienced sharp declines in volume, partly on their own account to keep themselves and their patients safe, and partly on the initiative of the patients of being fearful of visiting the physician's office. Now, I think video visits in particular have been very effective for some medical issues, such as management of chronic conditions and behavioral health. And it's clear that they're going to be part of the post-pandemic environments. But I don't think we're not going to go back to where we were before, where we had virtually no telemedicine, but I don't think we're going to continue where we are today. Because otherwise, I think we'd see some substantial overuse and fraud. So we're going to need new coverage and payment policies to be developed for some point that we switch from a public health emergency to normal times. Another area that's substantial is alternative payment models, such as accountable care organizations or ACOs. And this has been very disruptive by the pandemic, because basically, the practice of comparing actual spending over a year with a benchmark is being disrupted. The problem is that the impact of COVID-19 care and reduced use of elective services means that the impact of the pandemic are likely to greatly overwhelm ACO success or lack of it in making care more efficient. In a sense, windfall gains and losses to ACOs are likely to be huge, and that's not a good idea to allow happen. So MedPAC, in a letter to CMS, recommended not using 2020 spending data for determining either shared savings for 2020 or as a benchmark for future years' calculations of shared spending. It's probably wise to support some of the ACO activities, whereas putting the gains and losses on hold. I perceive that the interest in alternative payment remains strong despite this interruption and provides a good basis for supporting some of the activities in the absence of opportunities for shared savings. A final thing to note, and I won't have much to say on this, is Medicare financial support for providers. Historically, Medicare has provided some support for providers that are safety net providers that have large numbers of Medicaid patients and uninsured patients. But the notion of supporting providers generally is new, and I think Medicare's ability to jump into this quickly has likely been very helpful in maintaining our delivery system to get it through the pandemic.
Mm-hmm. Agree.
Thank you, Paul. Yes, and I think, as one of those managed care organizations on the MCO side, we are very invested in supporting providers, and they are partners in this. So new opportunities, coming out there. So I'm going to try to be a good steward of our time here, which I'm really a terrible timekeeper, so that's going to help. But if you guys could get your crystal balls out for a few minutes and talk a little bit about how the pandemic can affect the future of Medicare and Medicaid, and look a little bit down the road a piece. And Anne, if you're up for it, I'm going to bump over to you first, please.
Sure. Just a couple of things. First of all, I think on the Medicaid side, Medicaid programs have had a lot of flexibility on telehealth, very different than Medicare, although they've not necessarily been taking advantage of it. So the future of telehealth is going to be interesting. also a little bit concerned about, given that Medicaid has a non-emergency medical transportation benefit, sort of what's the interplay of the future of telehealth and that benefit. And part of that is in understanding the effectiveness of telehealth in different situations and for different services, and the ability of beneficiaries as well as providers to take advantage of those things. So that's one thing. The other is, I think we are really looking forward to a couple of very tough years for Medicaid programs. A lot of the innovation that states have been interested in pursuing, or whether that's around value-based care in general or social determinants of health, rebalancing, integration of care for dually eligible beneficiaries, integration of behavioral and acute care, really requires state capacity, and we're just not going to be in a period in which there's going to be a lot of state capacity. I think a lot of concern, not just about budgets going down, but also just generally loss of human capital in state Medicaid programs, loss of expertise, and not ability to change that. So while we've heard a lot, I think, in various sectors of the economy over the last several months about not letting a good crisis go to waste, I am a little bit concerned about whether the resources will be there to actually capitalize on those. And also very concerned about really what the future safety net looks like if we are not able to pay what we really need to, for whether that's direct care workers or physicians or hospitals or health centers. Is there really going to be a system of care there available? I think for managed care companies right now, it's sort of a strange situation. We just don't know whether, if the care that wasn't sought, whether that's going to catch up and how that's going to affect future rates. So I think a tremendous uncertainty on that front. So I'm, of course, always ever hopeful, but I think we're looking at a bumpy couple of years ahead.
Oh, I concur, and one to have really been pleased by so many of the opportunities we have dug up through this crisis, right? The silver linings of a little bit of innovation, lots of collaboration, sustainability, it is really going to be interesting. So I appreciate those sentiments very much. Paul, where's your crystal ball? What are your thoughts?
Well, one near-term issue is that the Medicare Health Insurance Trust Fund, which pays for hospital care and some other facilities care, that's its exhaustion is going to be sped up, of course, by the epidemic, both from, at least on the revenue side, this lower payroll tax collection because of the unemployment. And that's going to mean that the trust fund will be exhausted sooner, and Congress is going to have to focus on it, because exhaustion of the trust fund means that claims are not paid in full. And this is not the first time that Congress has faced exhaustion, and it's always acted usually from some combination of cuts in spending and increases in taxation to pay for the program. So that's probably going to have to be on Congress's agenda next year. The other big picture going forward is, what about cost containment? Given healthcare spending approaching 20% of the gross domestic product, and the havoc it's imposing on federal and state budgets, probably there is urgency. I think at the moment, nobody wants to talk about it because providers are hurting, and that's understandable. But once things get back closer to normal, I won't say they'll ever be normal again, this is going to have to be a focus, and probably some of it will be done in conjunction with addressing the trust fund.
Appreciate that. Passing the crystal ball around, John.
Well, let me take the opportunity to say something maybe a little radical, which is, why do we need HI trust fund? It's not reflective of the program as a whole. It's not the direction that the program is moving in, which is moving into a more integrated uh, set of arrangements, including outpatient and inpatient together. So I think the trust fund may be a anachronism that we no longer need. So I'll put that out there. But I do want to agree with Paul that cost containment is going to be a pressing, urgent uh, agenda for healthcare generally. Uh, the trouble, of course, with focusing just on Medicare is you end up shifting costs to the private sector, and Medicare is already more efficient than most private sector insurance. So I think it's going to be hard to have a focus simply on Medicare and not take a look at what the impact is on private health insurance. And finally, I do think that this expansion of healthcare into the social determinants is significant. And all the research shows that it's a much more effective way to keep people healthy and out of the hospital, provided we can target that intervention earlier. And I think there's a lot to learn there that would be good for healthcare, good for individuals, and good for the budget.
Yeah, excuse me, John. Yeah, I want to agree with you about how the trust fund is becoming, less perfect a tool. And
Yeah,
it's focused on a smaller part of the program. I mean, it's always been there just to force action.
right.
And I've often perceived that, in over the years, we've both watched various major decisions on Medicare, that it's been Congress's attitude towards the overall federal deficit, which has really driven their actions,
Right.
much more so than the trust funds. Even though I think the public focuses a lot more on the trust fund, it's easier. I think that trust fund has had value for forcing action, but uh, it's not as good at it as it used to be because there's so many ways to move money out of the trust funds
Right.
and really defeat it.
Right.
So I think we're going to have to give you guys an extra session on that one coming up soon. But I want to make sure that we get John Overlander in here with crystal ball before we take some Q&A.
Yeah, I mean, I'm a political scientist. You're better off getting your palm read than asking a political scientist what the future is. I did want to say, we're not good at the future, but we're okay at the past. And I want to say one optimistic thing before saying something less optimistic, which is, because I'm not sure we've mentioned this, that something else that's striking over the last decade is Medicare spending has grown at a much slower rate than just about anybody anticipated a decade ago. And that should give us hope and optimism that change is possible, and a lot of the slowdown in Medicare spending has to do with changes made in the Affordable Care Act. It also should give us great humility about predicting the future because we don't have a really very good record at it. The one last thing I wanted to say about this is, in terms of the crystal ball, is I think just looking broadly beyond Medicare, the COVID-19 pandemic has exposed once again how unjust, inefficient, and inequitable American healthcare is. Other countries are fighting this and struggling to fight it, but none of them has an arm tied behind their back like we do, also worried about a population that's uninsured and underinsured, and how do you pay for all this? And I think the question going forward is, what is the trajectory of the pandemic? Nobody knows. Given what's happened already, it would be foolhardy to really predict where we're going. And it's at least in the realm of possibility, unfortunately, that the pandemic could get a lot worse before it gets better. And if it gets a lot worse, both in terms of public health and in terms of the economy, it really could have a destabilizing impact on American health insurance and change the debate over healthcare reform. And then I'll just close with the favorite two words of any political scientist. It depends. It depends on the outcome of the 2020 election. And we could go in very different directions in the future of Medicare, depending on those results. And if Joe Biden is elected president, and if there are Democratic majorities in the House and Senate, then we could have a very serious debate, at the least, about expanding Medicare eligibility in 2021.
Agree. Thank you. And I agree. It depends. For sure. So I know we have, you guys are awesome. We have a couple minutes for Q&A. And while we wait to see if we have any cues for you to answer, I think, if you want to opine, though, on the opportunity really and on addressing healthcare disparities for people, right? Just as you were starting to say, this has opened up so many warts in our system. We have disparities that we need to address on the quick for our Black and Brown communities and people who are just disparately impacted by COVID-19, and the obligation really, both moral, ethical, and otherwise for healthcare and our social insurance structure to be part of the solution. So I would to the panel, to respond to that while we look to see if we have any questions.
So I have just one thought I want to put out there, because obviously the racial and ethnic disparities in health are both a reflection of things that are that have to do with access to actual healthcare services, as well as the social determinants of health. And I honestly am not completely impressed with the match between what we're talking about on social determinants and how the health system is responding with what we actually could be doing. I think, for example, Medicare sort of stuck its toe in the water here with some supplemental benefits. It's not that much. The amount of rebate dollars on the Medicare side that are available to pay for social determinants is not that much. And on the Medicaid side, similarly, there are some things that are being done around value-added services or in lieu of services, but the pot of money that's actually available to address social determinants, whether that's nutrition or housing or, it's pretty modest, and I don't see a lot that's being done on sort of the general issue around toxic stress. So I think that if we want to really do something about it, we're going to have to face up the fact that that's going to require a much more concerted effort, both on the access and on the social determinants front.
Right. I agree with that. But Meryl, let me also raise one other topic that we've not addressed, which is the cost of pharmaceuticals. I do think that comes back big time. And I would note that in the House, a very serious cost containment initiative is paired and would finance very significant Medicare expansions to cover hearing, vision, dental services. And I think that kind of charts a future for the program that would be very positive.
Yep, a big part of the conversation. You are right. We have about 1 minute to go. So let me just see if anybody can quickly answer. One of the questions we received is, what other revenue sources might be used to help fund Medicare beyond payroll contributions and premiums?
Well, I can answer that. I mean, Medicare has always been funded a great deal by general revenue.
Right.
And of course, the barrier there is that general revenues are pretty lean today. Not just at the moment because of the recession, but also because of repeated tax cuts and the like. So it really gets into what's the overall fiscal stance of this country. How viable is it? I don't think it's very viable to run deficits anywhere near the magnitude we have today or that we had before this recession began.
Yeah, it's useful to look at how other countries finance healthcare, and they generally do it through some form of consumption tax, whether it's a tax on carbon or value-added tax, something that we don't have in this country unless you count state sales taxes. So that's something maybe that should be considered going forward, is a different fiscal basis for the program that would help us in our international economic standing.
Yeah, interesting point, especially in the time of lots of global impact. Well, I can't thank you guys enough. You are fantastic, and I learned a few things during this panel as well, which I love. But before we go, I have to put my board hat back on before I get in trouble by the Academy staff here and board. That quickly remind folks about donating. I believe there is a link in the chat box for you to check out. And so, please check that out and help us out where you can. We want to also say, for those of you who have responded already, that our goal is to raise $100,000 by June 30th. And those who have responded already, really, you are helping us so much to help us get closer to that goal. We want to specifically thank the Commonwealth Fund for supporting at the research patron level, getting us right over that 70,000 mark. And also thanks to other research patron level sponsors, which would be the Blue Cross Blue Shield Association and the Buffin Foundation. If you're curious about where your donations go and what impact they have for the Academy and what they make possible, I know one example we have is that the Academy has been holding a series of virtual roundtable discussions in response to COVID-19. Those links are also in the chat box. I was able to participate in one last month where we discussed how the legislation so far has helped, sometimes not helped people with disabilities, very disability focused. There's a lot of work to be done to uphold the rights of people with disabilities, especially in the year of the 30th anniversary of the Americans with Disabilities Act. We flagged problems that people with disabilities are experiencing. We talked about some of the solutions for policymakers to implement. So even a $25 gift or ball award ticket sponsor ticket supports all of the tools like Zoom, staff time, because thank you again to the Academy staff for helping us out so much as we put this together. Speaking to what this panel has been discussing, the Academy also issued a large report earlier this year on Medicare eligibility to help policymakers who want to expand coverage. And when policymakers return to this issue, the report will provide them with the tools to get the policy design right. But in order for us to make that happen and make sure policymakers get that information when they need it, we do need to support our staff and the work done here. So thank you again. That's the last plug I'll do there on that, but I get one more. And after thanking you spending this time with you,